Hello, everyone. My name is Samir Mehta. I'm an orthopedic traumatologist at the University of Pennsylvania, and it's a pleasure to join you today as part of this session. I know you've already met Dr. Dasa, and he'll be joining me in this session on the economic insights associated with non-surgical treatment strategies. These are my disclosures, and these are the learning objectives for this part of the sequence. We're going to talk about costs associated with surgery and conservative treatment for fracture care, particularly in non-unions. We're going to discuss the use of orthobiologics as an adjunct to surgery and how these treatments can impact outcomes and reduce cost. And we're going to also outline how racial inequities impact the clinical and economic outcomes of osteoarthritis and total knee arthroplasty. So I'm going to start off with a case. I always like cases because I think it frames the discussion a little bit. PR is a patient. She's a 51-year-old female. She happens to be a nurse that works at an outside hospital. She fell and she slipped on ice and she had an open tibial shaft fracture. And this is what we call a type 1 open tibia. So it's a fairly benign open fracture, if you can consider open fractures benign in the grand scheme of things. This is her original x-ray. You can see it's a fairly simple fracture pattern. It's a slightly oblique tibia fracture with a very small wound, and she was treated with an intramedullary nail. Again, standard of treatment. It looks like it was done technically well. She received some antibiotics. Of note, she is a diabetic, so she falls into a little bit of a higher risk category, and she does have an elevated bone BMI, so she is a little bit, from a weight perspective, a little bit bigger. 9 months later, she shows up in my office with this on. So you have to wonder what happened between her original fracture care and fixation and then into this external fixator, ring fixator. There's lots of things that sort of happened in between, which I don't have access to, but you can see that her bone does not look great. Her bone quality is actually, it looks quite poor. And her ring fixator shows that she's got just a little bit of malalignment. Her fracture still isn't healed 9 months later, and now she's got some draining wounds as well. So this is really complicated now. It went from being a relatively benign issue to a much more complex issue, and becomes a little more risky. She's drained from her pin site. She has no callus formation, and her soft tissues look really poor at this point as well. And she's clearly infected. So we take her back to the operating room. Now she's my patient. I take off the ring fixator. I put in an antibiotic nail. We cut out that entire segment of infected dead bone and put in a cement spacer, which is what you see that circle around. And I put in an external fixator to give her some stability as well. That's what her soft tissue looks like. You can see the huge intercalary defect she has from, that's tibia down here, that's normal. That's tibia up here, that's normal. That's an antibiotic nail in the middle. And that's a cement spacer that we're putting on around that to give the local soft tissue some control. You can see the infection from the pin sites around her bone, around her soft tissue as well. It's not a pretty picture. And so this is her 8 weeks later. We put her in a different kind of ring fixator. We're doing a bone transport. This is her 11 months in. She's made some bone. She's got a wound that's not healing. I've got my plastics folks on board trying to get her to heal. And this is her at 14 months with a below the knee amputation. And so you say, well, wait, how do we get from a simple open tibia fracture to a below the knee amputation? And over 23 months from her index injury, she had 9 hospitalizations. She had 24 clinic visits, including infectious disease and home care. She had several treatments with IV antibiotics, which led to renal failure and neutropenia. She had 7 surgeries, and I can't even begin to calculate the cost of care in this scenario in terms of ICU time and surgeries, et cetera. And I bring this up because you have to wonder what the economics of this are. And I don't like to look at patients as dollars and cents, but we have to think about what our decision-making and how our decision-making impacts ultimately our ability to deliver care to everybody. And so we're going to talk a little bit about the economics of non-union fracture care, because non-unions are very common. Non-unions happen in about 10 to 20% of patients who have a fracture. So it is not uncommon for a patient to not have a fracture, that doesn't heal. And so managing that becomes really an important thing. Here's a gentleman who was involved in a sort of an accident at home. He was changing out his water heater or working with his gas pipes, and something triggered a fire and it blew up and it created this fracture, and that's part of his fracture pattern. You can see the devastation to his lower extremity, and this is not a trivial injury to treat. And when you think about algorithms for treatment, this is the algorithm for treating an open tibia fracture. So it's not clear and simple decision making. There's lots of breakpoints and decision points that need to be addressed. And as we look at this tree, we realize that there's a lot of opportunity here to intervene and prevent, hopefully, an event like you saw with our previous patient that leads to an amputation. So well, the question is how do we get to taking a complex injury or even a simple injury and getting them to heal without going on to a non-union? And when we talk about non-unions, you know, we look at a patient like this. This is a 16-year-old. She's a college athlete. She was at college when she broke her femur. She plays tennis at a Division I school. She had a rod put down her femur. We can argue about the type of rod that was used and should it have been used, etc. But this is the type of rod that was used. And this is her at 6 weeks. And while it's only been 6 weeks, you say, well, it's only been 6 weeks. She's totally healing. You know, she doesn't need any intervention. I would argue that a femur that starts to look like this may not be healing, right? So that's her at 6 weeks, and it kind of looks a little weird. And so, you know, we talk about what's a non-union. So how do we define non-union? And there's different ways to do it. Some people say it's a 3 months after an injury without healing. Some argue it's 9 months after injury. You can go through these numbers, but ultimately, you know, when we talk about non-unions, I think about Justice Potter. Justice Potter was a Supreme Court justice who had a famous saying around the concept of pornography. He said that he doesn't know how to define it, but he knows it when he sees it. And so when we talk about non-unions, I would argue it's the same thing. I'm not sure how to define it, and there are different definitions. The one definition that's commonly used is no significant callus formation in 3 successive x-rays that are 1 month apart. And so when we look at this patient, yes, she is sort of showing bone formation every, you know, time we see her, but she's not uniting. And at her 6-week x-ray, I was already concerned. And this is her last set of x-rays was done at 6 months before we intervened. She was complaining of thigh pain. She felt instability. It did not feel right. And so she went on or went to a non-union, but at 6 weeks, she was already showing signs of it because it's a femur. And so if it smells like a non-union or it looks like a non-union, you have to be concerned that it could be or is a non-union. And there's several factors that impact fracture healing. So when we think about fracture healing and non-unions, you know, why do people get this? Yeah, it can be the blood supply to the bone. So in this scenario, in this picture you see here, this is a nun. She had a rod put down a femur fracture. Several cerclage wires were used, and those cerclage wires strangulate the bone, and it's possible that the cerclage wires, you know, affected the blood supply to the bone and led to her non-union. We know that biomechanics affects fracture healing. So fractures that are fixed well versus those that are not fixed well or overfixed can lead to non-unions. Obviously, infection can lead to the bone not healing. This is a patient who was hit on the interstate and was fixed, but he had this draining wound and was draining for months. And if you look at his x-rays, clearly he's not healing, and the infection can cause that. And then there's things like host factors that will put people at risk for not healing. So these are things like smoking, diabetes, vascular disease, if they take certain medications. So there are things that, if they have a thyroid disease, so there are certain things that biologically put these patients at risk compared to other patients. So when I talk about my level 5 approach, I say level 5 somewhat tongue-in-cheek, I do have a process when I look at a patient in terms of how I approach this to either prevent or manage a non-union. I think the biggest issue is anticipation. So you recognizing patients who are at risk, whether it's their injury mechanism or whether it's their protoplasm. They may be like our first patient that I showed you and ended up with an amputation. She was a diabetic with an open fracture. This puts her at risk. So anticipation is really key. Prevention, so doing things before they get to the non-union is really important. So this is things like good soft tissue management, diabetic control, making sure they're taking vitamin D to help with fracture healing, using things like LIPUS to help fractures heal, because one of the other things I tell my residents when I teach them all the time is fracture healing is a race. It's a race between the fracture failing or the hardware failing that's holding the fracture together and the bone uniting. And so eventually all hardware will fail. That's a fact, right? All hardware will eventually fail. It's really a matter of when. And so when we approach patients who have or are at risk for a non-union, I think doing what we can to prevent them is really key. So identifying a non-union is really important. So getting x-rays. So these can be hypertrophic, which means they're making bone, like the tennis player I showed you. She was making bone, but she just wasn't coming together. Or atrophic, which means that they're not making any bone, and there may be a biologic reason for that. These patients also require time. They require time in the hospital, and they require time in the clinic. They require a discussion about what's happening. And one of the things that one of my mentors used to tell me was the difference between an excuse and an explanation is timing. And so if you tell a patient in advance, listen, you're at risk for a non-union. You had an open tibia fracture. You are a diabetic. You had a bad soft tissue envelope. We did X, Y, Z for you preoperatively or intraoperatively. We've put you on the LIPUS postoperatively, but you're still at risk. Then it's not a surprise. They also need to help sometimes be taken through the decision-making involved in fracture healing and in what the options are as they are not healing. These patients all require an infection workup. You know, infection is the great imitator sometimes. And so even if they don't have a draining wound or a big open, you know, they're not septic, you can still have a low-grade infection. And so an infection workup is really important, along with a metabolic workup. So understanding their biology. And we're learning more and more that a patient's biology is really important in fracture healing. And then I don't think there's much role for advanced imaging, but you can get a CT or an MRI if you need it for your pre-op planning, but advanced imaging may not be of tremendous benefit. And then lastly, these patients require a tremendous amount of planning. So when I look at my non-unions or take care of non-union patients, there's a lot of planning that goes into it. And so as we think about this and we think about fracture healing, we know that there's a lot going on in the backdrop. And I don't begin to even get into the science of fracture healing. I am not a basic scientist, but I recognize that this is a real complex interplay of multiple things. One of the things that this slide reminds me of is we hear about people putting in different biologics. They'll put in a single protein, and I think about fracture healing like baking a cake. I would never bake a cake with just a bunch of flour or just a bunch of sugar. I would have multiple ingredients, and I think fracture healing is very similar to that, which is why I think certain treatment methods make more sense than others if they're ramping up the entire pathway system, not just one particular protein. We know that there's a tremendous economic burden of non-unions, right? So we know that 10 to 20% of patients will go on to a non-union. We know that non-unions are a multi-billion-dollar issue in North America. And so we also know that as we think about non-union management, when patients go on to have a symptomatic fracture that hasn't healed, that patients who are treated with surgery actually have higher medical costs than patients who are treated with low-intensity pulsed ultrasound. And that low-intensity pulsed ultrasound is a cost-effective alternative to surgery. Now, not every patient is going to be able to be treated with low-intensity pulsed ultrasound, frankly, because they may have a fracture that's failing or they may be infected. And so there are other reasons to do surgery, but from a cost perspective, there may be a direct cost benefit to utilizing low-intensity pulsed ultrasound. Some argue that, well, what if you already have metal in place? Will that affect the ultrasound from getting to the fracture, or will it affect the ultrasound waves hitting the metal? And we know that ultrasound and metal can work together, that there's no deficit from having metal in place, and that we can treat a patient with a non-union who has metal in place with ultrasound. There's lots of evidence about non-union treatment in patients who have been treated with ultrasound, patients who've had long-standing non-unions, and their only treatment is ultrasound, showing that you can take a patient who's had a non-union for 1 year, 2 years, 3 years, and be able to treat them with ultrasound, assuming they have a stable fixation, they don't have infection, etc. In this study, they showed that it was a prospective series of 29 non-unions of various types: atrophic, hypertrophic, oligotrophic. The fracture to age was about a year, and they'd already failed surgical treatment. And you can see with ultrasound that a large percentage of these patients healed. Even the high-risk patients, like the smokers, healed with just ultrasound treatment. Another prospective case series of 67 non-unions. Again, these long, sort of drawn-out non-unions. Ultrasound treatment was the only treatment rendered, 85, 82% non-union heal rate. I will tell you that if I could get, and I could promise my patients 85% heal rate with surgery after a non-union, I would take it. So, these numbers are comparable in some ways to what we get surgically. This is a randomized controlled trial showing that it was increased bone mineral density in patients who had a non-union treated with low intensity pulsed ultrasound. In this case, it was exogen, and there was a high compliance rate. So all of these things are showing us that treatment with ultrasound actually makes a huge difference in terms of bone mineral density and healing. A meta-analysis showed that the LIPUS heals non-union fractures. And so this took data from various sources, the meta-analysis, right? So it took data from multiple sources, sort of collated all that data and showed us that non-unions treated with ultrasound, some of the data I've already shown, but this is sort of bigger, show that fractures can heal that way. Now, I want to be mindful of the data that I share. This was a study published that showed that there is very little impact of ultrasound in all tibia fractures treated with ultrasound, low intensity pulsed ultrasound. Now, the reality is that when you look at this study, they treated all patients, not high-risk patients, not non-unions, and there was variable utilization of the ultrasound device. And I think that's really important. We know that if you use this and use it the way it's supposed to be used on a consistent basis, on a daily basis, that it can improve fracture healing. But there may be limited use in those patients who are not high risk or don't have a non-union. That still needs to be determined. But in the scenario of a patient who's either high risk or a patient who is already a non-union, there's clearly value, and the data has shown that. So I love this slide because it reminds me that data is really born to some interpretation. It's parachute used to prevent death and major trauma related to gravitational challenge. Systematic review of randomized controlled trials, and the caption in this British Medical Journal article says, parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized controlled trials. And I find that very interesting as sort of a somewhat comical, but also reminds you that not everything can be or has randomized prospective studies, yet we still comply to it. So I think it's important for you to weigh the evidence as you think about what you're going to do and how you're going to do it for your patient. So I'm going to share a last sort of scenario with you, a last case with you to kind of show you how complex these patients can get. This is a gentleman who was injured back in 2008. I didn't treat him initially. He was treated in an outside hospital after a motorcycle crash with an intramedullary nail device. He went home with a low hemoglobin, and it turned out that he was bleeding from his fracture site, and he was taken back to the outside hospital for an emergent vascular repair where they did additional surgery to him. And then he went back again about a year and a half later because he wasn't healing, and they put BMP into his fracture site to see if they could get him to heal. He comes to see me almost 3 years later with hip pain, not femur pain or thigh pain, but hip pain. And he's got about a 3 centimeter leg length discrepancy. So clearly, he doesn't feel good. His hip is bothering him. And, at this point, people think it's his leg length discrepancy, but as you do a deeper dive, his fracture is actually not healed. And you can see the fracture line. If you look at this image, you can see that there's a fracture line that goes through it. You can also see how this bone just doesn't look normal. So I did a non-union workup on him. His vitamin D was low, his testosterone was normal, and he had a normal infection labs, despite having this sort of infectious type picture. He had multiple surgeries to the site, and maybe I should have treated him like an infection patient. So I had a long sort of discussion with him and myself about what to do, and ultimately I did a 2-stage procedure. I assumed that he was infected and said, listen, we're going to treat you like an infection. So we debrided the non-union, so you can clearly see it in this fluoroscopic image from the operating room. We used an antibiotic nail. We did a 2-pin external fixator, and his intra-op cultures were negative. So I said, all right, so you're not infected. We're good to go. I then took him back. I put a rod down his leg. I took out that intercalary segment of bone that I was worried about, that I didn't think was alive, and I put a cement spacer in there. So I put an antibiotic cement spacer, again, with the idea that, well, maybe he's infected and this bone isn't great. And you can see that maybe I got an incomplete resection, but I thought it looked pretty good. I then filled this with bone graft. And so I brought him back again. I took out that cement spacer and I put bone graft in there. And then our decision was, let's get you to heal your femur, and then we'll lengthen your leg over time. He said he was feeling great. He had a stiff knee, but I wasn't impressed by his bone formation. And so about 6 months after I started treating him, he felt a pop in his hip. and you can see that he broke the screw at the top of the femur. So unfortunately, he didn't make enough bone here to maintain the gap and fill in the gap. And as I said before, all fractures eventually fail. And so you can see here, he broke his, he broke the screw at the top of the nail because the fracture failed. Okay, he had more pain. I wanted to give him some time. Let's get him to heal. I can always lengthen him later. But ultimately, you can see he's shortening. Now the nail is sticking out farther. There's more displacement. He's got more pain. I haven't used any ancillary treatments like bone stimulation or anything like that at this point. Now he's 6 centimeters short. I've revised him. I've tried to get him to heal. So I now back to the operating room again to see if I can get him to heal. So I just put a new nail in. I leave him shorter. Just again, the idea is to get him to heal, and then I'll get him out to length. He feels great. He's got no pain. His fracture's filling in, and he's ready for lengthening. And I sort of buried my head in the sand a little bit, because if you look at that x-ray, and I'm looking back at this case as I show it to you, I'm like, what was I thinking? But I'm convinced myself that, yeah, he's healed enough that I can start lengthening him. So I take him back to the operating room, and I start to lengthen him, and I make an osteotomy above the area that I think is healed. So here is where I make the osteotomy, and I put him on a low-intense pulsed ultrasound device 20 minutes a day to see if I can get him to fill in that bone distally down here where the other sort of bone grafting was. So he starts lengthening. He has no complications. He's following his instructions. He's weight bearing. He's feeling good. You can see that he's lengthening his osteotomy site, and he's using the ultrasound. Well, the ultrasound's really effective, so effective that actually he starts to consolidate his osteotomy site, and he's made so much bone at the osteotomy site, but I'm still pulling. He pulls through the site that hadn't healed, and that was not really great bone. And so my ultrasound worked great to get the osteotomy to heal, but it healed way too fast. And so I take him back to the operating room. Once he's out to length, I put a new nail in him, and I took out the old interlocks, and then you can see that he's filled in his osteotomy site, and he's starting to fill in his other fracture site. I have a video of him jumping that doesn't play very well because I think I lost it, but I have this screenshot from it. And this is him. His leg lengths are equal. He's showing me how he raises his pants up and his shoes look great, and he's jumping on it. But then he feels some pain, and he feels a pop again, and he never healed that intercalary defect. He had stopped using his exogen and really was sort of thought he was over the hump, but he really wasn't. So after all of that, I take out that area of bone that has not been healing. I shorten him again. I put in a new nail. I put him back on the ultrasound. I lengthen him over time. I finally get him out to length. You can see the bone formation that's happening with the ultrasound and the new rod. And ultimately, at 6 months after this surgery, 34 months after I saw him, I finally get him to heal. And I share this case with you because it shows you the complexity of fracture healing and all the things that go into it, and also all the things that can go wrong. So he had 47 months, 8 surgeries, and 40 office visits to get him to heal, and with a lot of adjunctive treatment. And I think the adjunctive treatment made a huge difference. So I want to thank you for your time and your attention. I know that's a lot of information there in a very short period of time, but hopefully it gives you an insight into some of the complexity involved with these cases, and also how certain things can help facilitate the healing of these fractures before they get to this really complex scenario. I'm going to turn it over to Dr. Dasa now for the rest of this particular session. Thank you.
Thanks, Samir. So next, we're going to talk about racial inequities in the management of knee OA and total knee replacement. So this is a space that's near and dear to my heart in our research program here at LSU, because for good or bad, Louisiana has a significant amount of health disparities. And obviously, it's coming to a head right now in real time around the US and actually worldwide. So Louisiana, we have the second highest percentage of Black Americans. We have, unfortunately, a significantly high number of individuals that live below the poverty line, and a significant number of patients that are on Medicaid. And with Medicaid expansion in Louisiana, we saw a lot of the health disparities and the inequities really become much more apparent than they have in the past. And so over the last few years, our department and our research program has really put a lot of emphasis and resources into understanding health disparities and their impact on outcomes. So osteoarthritis in general is the most common joint disorder in the US. 2005, 27 million Americans suffered from OA. You can see the gender demographics here. It's more common in women. And obviously, as you get older, we would expect OA to worsen and become more commonplace. So osteoarthritis is the loss of articular cartilage within the knee. The analogy I use with a lot of my new patients that come see me that have OA is it's similar to when you snap open a turkey joint during Thanksgiving. You see that smooth, white, shiny stuff. When you do that, imagine you took a fork and started scraping it away. That's called arthritis. And so some of the other anatomic changes that we see are osteophyte formation, inflammation, attenuation of the ligaments, so on and so forth. And the most common clinical features are stiffness, difficulty with ambulation, trouble going up and down stairs, decreasing range of motion, deformities, things like that. And so when we look at OA, non-modifiable risk factors are listed, and the modifiable risk factors are somewhat up for debate. And can you really, in a lot of patients, really impact the obesity issue? You know, we've all, as clinicians, struggled with getting our patients to lose weight. Probably a lot of us ourselves have struggled with doing that. So, you know, traditionally what we think are modifiable risk factors, even smoking, how do we manage that and how do we deal with that? And truly, is it really practical to withhold treatment or withhold surgery until they fix these things, which many of us struggle to fix ourselves? When we look at the paradigm and the treatments of osteoarthritis, obviously we start with a non-operative and non-surgical management first, weight loss, exercise, physical therapy. Then we start becoming more and more aggressive with over-the-counter and then prescription-based treatments. And then we get into more interventional-based treatments and then ultimately surgery. So I think as an orthopedic surgeon and a subspecialist, a lot of our patients have really failed these first two steps before they come to see me. If those steps work, they probably would not have come to see me. And so oftentimes patients hit my office or hit the specialist office really here. And so what are the opportunities to intervene after they failed a lot of these kind of pre-specialty treatments and interventions, if you will? So total knee arthroplasty is the most common surgery performed in the United States, and it's growing significantly. Most everybody knows hip and knee replacements, the trajectory of those surgeries is significantly growing. And so how do racial inequities impact all of this? And so if we look at the health economics data, the inequities and the disparities that we see Black patients or non-white patients exposed to really cost the system a significant amount of money. And so if you look at direct and indirect medical expenses, you can see how much money truly is being wasted purely because of the color of somebody's skin. And so there's an economic imperative, not just a moral or ethical imperative to really fix what's been going on for centuries, but there's really an economic imperative as well, motivation. Now that reimbursements are going down and value-based care is here, we're talking more about population health and managing communities. So we have to fix this from an economic perspective as well. So if we look at the impact of racial inequities in management of knee OA, this is a very large study that's been ongoing for some time, the Johnson County Knee OA Project. This was a study looking at differences in OA in Black patients versus white patients. And we see no difference in incidence of OA between white and Black patients. In other words, OA is happening equally between both groups. But what we're finding is degree of progression and the manifestation of OA is worse in the non-white patients compared to the white patients, even after we compare control for all the variables that you see listed. So this was another retrospective chart review looking at the difference in outcomes in our surgical patients, Black patients versus white patients. And what they found was utilization of both hip and knee replacements significantly higher in white patients compared to non-white patients. And then when we look at complications following surgery, you can see here, not just getting the surgery was a barrier, but actually after you have the surgery, we're seeing significant differences in complication rates in Black patients versus white patients. So if we do a deeper dive into those complication rates, what do we see? If you look at UTI, PE, DVT, renal failure, sepsis, we see a significant difference in our non-white patients compared to our white patients, even after controlling for all the variables that you see here, age, sex, smoking, medical comorbidities, so on and so forth. So there's inherent bias within the system that goes well beyond the actual biology that we when we try to explain what's going on. When we look at another retrospective chart review, and we look and now at revision joint replacements and the impact of race and inequities on this, what we see is a similar trend, right? A higher utilization in white patients compared to non-white patients. We see the same thing in revision knee replacements. But what's concerning here is actually in the revision space, we see more Black patients getting revision total knee replacement compared to white patients. So not only is utilization higher in the white patients, but then the issues with failing total knee replacements is actually higher in Black, despite Black patients having lower access, right? So you can start to see there's some fundamental issue in healthcare about how our patients are being treated purely based on the color of their skin. So as I said earlier, we've really bit into this and sunk our teeth into understanding the racial inequities that we're seeing. And at our research program, in our clinical practice here at LSU, we are taking care of a significant number of non-white patients purely because that's the population that we serve and that's the community in which we're in, but also that's part of our mission is to give fair, balanced, and equal treatment to all the patients in our community. So we started a research project looking at the patients that present to our office with NeoA and understanding what their symptoms are based on racial differences. So we took all of our NeoA patients and we characterized their demographics, which you can see here. You can see we actually have in this group a higher percentage of non-white patients compared to white patients. You can see we've got a significant nice spread in terms of insurance type. You can see the severe OA, bone-on-bone OA versus the non-bone-on-bone OA, BMI, Charlson Comorbidity Index, and then the KOOS scores, our pain and function scores that are now pretty much the standard when it comes to CMS, trying to figure out and try to measure quality. And what did we find? So the patients that came for their initial visit, their first new patient visit that had a diagnosis of NeoA, what did we find? What we found was a significantly worse score with KOOS symptoms, KOOS pain, and KOOS ADL. No significant difference, statistically significant difference in KOOS quality of life. So Black patients, when we control for BMI, when we control for Charlson Comorbidity Index, when we control for gender, when we control for KL score, when we control for all these variables, what we found were the non-white patients were coming in for the same level of arthritis with significantly worse symptoms compared to our white patients. We also wanted to look at how our non-white patients were doing compared to our white patients in the context of a pretty, what I would say, bread and butter surgery, arthroscopic meniscectomy. And so what we found was our non-white patients were actually starting off at a lower point compared to our white patients prior to knee arthroscopy for meniscus tear. But what we found post-operatively was a little intriguing. Our non-white patients actually caught up to the white patients 90 days after their knee scope. So in other words, they were different going into surgery, but the surgery actually equalized and normalized the relationship between white and non-white patients. So in other words, there was an access issue, but when given access, the patients were actually able to equalize and perform at the same level. So if given the chance, what we're seeing, at least in this, with a fairly bread and butter surgery that doesn't require a lot of resources and fairly straightforward postoperative recovery, we're able to actually level the playing field, if you will. What we did find, however, was a difference by insurance. So the Medicaid patients did not do as well preoperatively and did not do as well postoperatively. So what this shows is actually access to resources and access to care is actually one of the biggest gating items and influences in terms of how patients do, not necessarily the color of your skin. So if you can get them access, patients will actually do well. And so the barrier is really access. And so the color of your skin goes hand in hand with access. But if we can tease out that difference, we actually can move the needle and make a difference. We're also additionally trying to understand and figure out what are the basic science drivers around the differences we see in outcomes. And so in our patients that are undergoing total knee replacement, we're actually cataloging and warehousing their tissue in a tissue repository or a biobank on our total knee replacement patients. And so what we found is at the time of surgery going into a total knee replacement, we see a statistically and clinically significant difference in our Black patients compared to our white patients in their KOOS pain, KOOS symptoms, and KOOS ADL scores. What we found also was there was a difference in range of motion in our white patients compared to our Black patients, both preoperatively and postoperatively in our total knee replacement patients. So remember, total knee replacements is a much more resource intense procedure, much more sensitive to access to care compared to our arthroscopy study what we were doing. And then we looked at some of the basic science explanations of why our Black patients may have decreased range of motion and worse symptoms both before and after surgery. What we found interesting was that we actually saw a difference in synovial fibrosis in our non-white patients compared to our white patients. So the next question then is why? What are the environmental drivers? Maybe it's nutrition, maybe it's access to care, maybe it's a number of variables that we have to do a deeper dive into. But what we're seeing is these social determinants of health are actually impacting our patients biologically, which is then impacting their outcomes following more complex surgeries, such as knee replacement. So both acute and chronic pain in Black patients has been shown to consistently be different and undertreated in our non-white patients compared to our white patients. They're also more likely to underreport their pain. Black patients, again, have an access issue, 40% less likely to receive a total knee replacement, despite increasing utilization of total knee replacements over the past 10 years. And we can see they're at a much higher risk of having a revision knee replacement, despite having poor access to that surgery to begin with. So despite most of our population being Black or non-white, these individuals continue to experience higher rates of health inequities compared to their white counterparts. Orthopedics has the least racial and gender diversity of all medical specialties. So why does this matter? So why do we still have inequities in 2020? So there's lack of awareness of racial inequities, especially amongst some physicians and some providers, thinking that they themselves have no bias, but we'll get into some of the explanations of that. Possible lack of empathy. When you have privilege and you may not live the life of some of your patients or understand what they're going through simply to get to your office, maybe they didn't have bus fare, maybe they had to change 3 different buses, maybe they ran out of gas money, what have you. Do you really understand what our patients are going through? Inadequate emotional regulation. Clinicians with good emotional regulation are less likely to stereotype patients. And then interracial anxiety. White clinicians who want to avoid prejudice can develop anxiety when interacting with minority groups, which results in lower quality judgment and negative body language, which then leads to this concept of implicit racial bias. And so the 2 types of bias are explicit bias, which is what you'd expect from someone who's overtly racist that you see on the news or that we've come accustomed to over the decades. But really the more insidious type of bias is this implicit bias or unconscious bias, nonverbal behaviors, body language, and this has been assessed and validated with tests of physicians and all other professionals. And it's something that potentially providers and physicians can do a better job of monitoring themselves. So with that, I would like to thank you for your attention and understanding and appreciating some of the challenges that we have in healthcare, that we have really a moral, ethical, and economic imperative to try to improve and hopefully solve. So with that, I will pause and hand it over for comments and questions. Thank you for your time.
Thanks for joining us for the final Q&A session of the day. Thanks for sticking with us throughout the day. Hopefully you enjoyed that presentation around health disparities and inequities. Let me turn it over to Samir and we'll kind of talk through some of the issues we have with health disparities and inequities. in the context of knee OA and arthritis and arthroplasty, we're seeing, especially on the elective side, a lot of issues in terms of differences in outcomes, which can be linked to difficulties in access and maybe biases in how we treat patients and assumptions that we have. Samir, on the trauma side, what do you got? Because that's not elective, right? I mean, someone breaks their femur, they break their femur. So, it's not necessarily an access issue. Ambulance comes and picks them up and brings them to your ER. So how does it manifest itself kind of this day and age, especially over the last 18 months, 2 years? Things have changed quite a bit.
Yeah, so I mean, I always remind people that orthopedic trauma is socioeconomic agnostic. Different people break things doing different things. Whether they're jumping out of a burning building or they're playing softball, they will sustain some kind of injury. I think there's a little bit of a misnomer that trauma is associated with, and you can fill in the blank. I work in West Philadelphia. We do have some gun violence here, but unlike what people may think, I don't take care of only people who have ballistic injuries all day. We have people who I recently took care of a young man who went to his first day of college and fell out of a third-story window. And his family lives around here, and so they brought him back here for his treatment. So there's a wide array of patients who get injured, and they, regardless of their insurance status, the acutely injured patient gets treated. At least at our center, they do, and I think most centers will do the same. It doesn't matter what their insurance status is or the socioeconomic status is. I think where the discrepancy sometimes falls into play is situations where patients don't have emergent injuries, things that are not hot trauma, like we say, things like car accidents where they have an open femur or open tibia. But those injuries that are, I don't use the word elective, trauma isn't really elective, but that are subacute or cold. It's the gentleman I saw a couple of days ago in my clinic who fell from, he works on stilts. He is uninsured. He fell off of the stilts painting a house and he broke his kneecap. It's a patellar fracture. It is a surgical procedure. He can't straighten his leg out, but he has no insurance, right? And so how do you take care of that traumatized patient in the setting of something that is not an emergency, but is an urgency? I can't wait for 8 weeks while his paperwork goes through to address his pathology, because 8 weeks from now, it's a very different surgery with a very different outcome. So that's, I think, one issue that we see, or where we see trauma manifest itself. I think the other area that we see trauma manifest itself with socioeconomic disparities is what happens to patients after the hospital, right? So they get cared for their femur or their tibia, but what about the rehab and the braces and the special splints you might need to get your range of motion, or the extra therapy that you might need? What happens if there's a complication like a nonunion or an infection that may not be an emergency or urgency, but does need to be treated? So it does manifest itself not, again, in that acute traumatic event where patients come in and are treated immediately, but rather what happens to those colder injuries or those elective trauma fractures, and those patients who then need something post their acute intervention. And that's where we do see a tremendous amount of disparity.
Yeah, I agree. And I've heard our trauma folks, we'll see a bimal that was seen at whatever hospital, 50 miles away, and they can't get in anywhere for whatever reason. And then all of a sudden it lands in our office 3 weeks later, and now you're picking up the pieces and it becomes a much more problematic surgery. On the arthroplasty side, or kind of on the chronic illness side, we're starting to see a lot of research come out about, outcomes. We're looking at infection rates. We're looking at PROs, patient-reported outcomes, pain and function scores at 6 months, and access to physical therapy. And, we are trying to figure out, especially here being in the Gulf South, where we have, fortunately or unfortunately, health disparities that we can study, trying to piece together, number one, what are the factors that are driving this? So, for example, one of the examples I use is bone quality. If someone's got poor bone quality, we know their outcomes after surgery are not as good, whether it's a hip or knee or what have you. Then the question leading up to that is why do they have poor bone quality? Well, they live in a food desert and they don't have access to nutrition, and they can't move to the neighborhood with, all the bells and whistles, because they weren't allowed to buy a house until 1965, Fair Housing Act. And so their generational wealth and family wealth is built on in the house that's way over here that has no grocery stores. And so that's why they have poor bone quality, and on and on. And, and so what are those factors that lead to this? And so where can we make inroads in this to try to figure out, how to mitigate or try to improve on some of these factors? And it's a challenge, it's so multifactorial. It's so kind of insidious. We're actually working on a paper right now that we submitted. We looked at all the level 1 studies in JBJS and CORE, and we looked to see at all the randomized clinical trials, how many even included race in their table 1, right? Did they include insurance? Did they include race? Did they include ethnicity, socioeconomic status in their demographic table? And sadly, less than 10% did.
Yep.
Right.
Go ahead. I finish your thought because I want to follow up with something there. It's really important,
and so, part of the burden is on us, because you had every ability. If you're doing a prospective randomized controlled trial, you have every ability to pull in the data elements that you need to pull in. You pulled in gender, you pulled in age, right? You pulled in all these other things, but not this. And so that makes you start to think, is the burden also on us, especially in academics, to start paying attention to these variables? Because we know that these variables get risk adjusted. When they're there, you need to adjust for them in your regression analyses, right? Because we know that they have an impact, but yet as academicians and researchers, it's not even important, or we're not giving it the importance that it even deserves to be listed as a variable that we're going to control for in our research. And we pulled the data up to 2019. So this isn't like we're talking about 1970 here. This was, a year ago. So we've got a lot of work to do just ourselves, let alone society, if we think it's important.
Well, and your example is great. I mean, it's so true. I mean, I will give you another example. We, as everyone knows, we're in an opioid crisis. We are looking at ways to mitigate or eliminate or limit the number of opioid prescriptions. But one of the things the health system is also focusing on is limiting the number of unused pills in the environment. Philadelphia, for those of you who might be interested in this area, parts of Philadelphia have made the national news because of the effect of the opioid epidemic in our region. And so the health system chose to undertake a pilot with our department, looking at the number of leftover pills that we were prescribing. So I would fix an ankle. I would give the patient, as an example, 28 oxycodone. Okay, that was historical. And what the health system would do is they would text the patient and say, how many pills do you have left? And at 7 days, how many pills do you have left? And they would get that information back to me to show my overprescribing. How many pills was I leaving out in the community? And what they were showing us was that we could start to cut down the number of pills we were prescribing, because the utilization was X, we were prescribing Y. Pretty straightforward stuff. What we started to realize was that we were obviously overprescribing, so we were able to eliminate excess pills in the environment. But when we looked at who was responding to these text messages, we found that the socio-demographic population that was responding to these text prompts for information did not match our patient population. Right? So now we're making decisions about something like pain medication, pain treatment, based on a skewed data set, right? And that disproportionately might affect another ethnicity, race, gender, socioeconomic group, et cetera. And so we have to be very conscientious, to your point, of as we amass data, as we look at studies, as we do meta-analyses or systematic, are they truly representative of our patient population, right? Are we able to make broad strokes based on a small piece of the data? Does it really represent the majority? And it's a challenge.
Yeah, no, so we've got a question here. I'll read it to the audience. I struggle with access to supervised therapy for my 18-year adult Medicaid patients, as they are required to utilize hospital-based therapy. It's at least 35 to 45 minutes for my patients to travel. I also share a building with a private therapist. I'm guessing the therapist doesn't take Medicaid. How have you found ways to work around this? I think there's a major factor for many of my Black patients. Yeah, the challenges is with the payer and the insurance. And so, there may be a conversation to be had with the private therapist that's with you and say, listen, I'll send all my patients. And when I mean all, the higher paying and the lower paying ones, but in exchange, you'll get my business or whatever business comes this way. It's horse trading to a certain extent. But I struggle with that as well. Obviously after knee replacement, there's a lot of therapy that's involved. And, I try to push my patients to our therapist at our hospital, partly because I can manage the outcomes as well. If I throw them out to the community, I see a hodgepodge of outcomes, whether you're commercially insured or Medicaid or what have you. I kind of funnel everybody to our therapist because, as Samir was talking about, we've got we're managing our opiates. We're now doing opiate-free outpatient total knees. In order to accomplish that, I need to have tighter control around managing that patient. And so I just tell most of my patients, I want you to come here regardless of transportation if you can. But there's no great solution that I've got.
The other thing I will say in some ways that COVID has been is a great disruptor. And COVID has shown us that we can do things a little bit more remotely. This does require technology, requires maybe access to the internet. But there are ways potentially, and there are resources, and there are third-party vendors out there that are providing in-home, web-based, or online physical therapy, or exercises, if you will. It's not free, but again, if you partner with one of these third-party vendors, it is possible to potentially not only provide this for that select group, but for the majority of your patients, and be able to give them access to at least some kind of physio. And I know in the joints world, they're doing a lot of this, online based or web platform based home therapy. They're also able to collect outcome measures as well. So there's multiple sort of aspects of that. You can track what your patients are doing if they're logging in and actually doing the exercises, and the physio. And so I think there are opportunities that are not traditional that you can look at as well for some of your patients. But it will require an investment potentially on your part. But if you make it part of a larger part of your practice, it may be cost minimal for certain aspects of your patient population.
And depending on your health system, there may be a population health angle, depending on if you're at risk for managing these patients. So a lot of the Medicaid plans are starting to kind of partner up with IDNs or health systems to manage, this global population. So deploying these resources actually becomes a cost saver and actually helps revenue. Because you're preventing downstream problems. So, I don't know if there's an opportunity at your practice or your health system to kind of look at it from that perspective and talk to your administrators and see if there's an opportunity there with some of these patients to drive down costs since you may be at risk. And so helping from that perspective, like Samir said, maybe they'd be willing to invest in telehealth or tele-rehab or teletherapy or what have you. And manage therapy remotely. We are seeing a growth in that space. And so, that may be an opportunity to kind of help mitigate some of these disparities by improving access to care, by lowering the cost of that by using technology. So we'll see. I'd like to thank everybody for spending the day with us. We're up with the clock. I hope you learned a lot from today. I hope it was worthwhile for you. I'd like to remind everybody to ensure that you log in and grab your CME credit. That's available on the website. And if you have any questions, feel free to contact us. Take care, everyone.